an anaphylactic shock protocol. To start, initial medical care, if ABCs are compromised, go immediately to the critical or severe portion of this SOP, which we'll cover in a little bit. Patients are going to get repeat assessments for a patent airway edema, wheezing, respiratory effort, inadequate perfusion. Ask about history of allergies, determine if they do have an EpiPen and if it's ever been used. Apply venous constricting band proximal to bite or injection site if swelling is raising rapidly. For instance, if they get stuck in the hand, we can put an IV tourniquet on their arm above the site. Attempt to identify or remove an inciting cause, i.e. a stinger or food that may be causing the allergic reaction. Apply ice or cold pack to a bite or injection site unless contraindicated. Do not start an IV or give meds or take a blood pressure in the same extremity as a bite or the injection site. Local reaction. It's going to be isolated hives or edema at the site of the exposure or GI distress after food ingestion. Observe for progress in transport. A mild systemic reaction, so their airway is stable, no airway compromise. They may have signs and symptoms of nasal congestion, sneezing, periorbital swelling, so swelling around the eyes, a rash, itching, tearing, or lungs are clear. Systolic blood pressure is above 90. We'll give them diphenhydramine or Benadryl, 1 milligram per kilogram, max of 50. That is a BLS skill, IM, or PO. We're going to try and do that in the leg, or you can provide it through an IV. Please caution, big time. If you are going to be providing Benadryl through an IV, please push it slowly. If you push it too quickly, your patient will vomit. So moving on to the moderate systemic reaction. To determine if it's mild, moderate, or severe, they are using this rule of 2+, the 2+ rule. So there's a likely allergy or allergen and signs and symptoms of 2 or more systems occurring rapidly after exposure. So patient could have anxiety as well as skin signs, itching, flushing, hives, or swelling or edema to the skin. Their mouth and throat could involve drooling, edema of the airway, swelling of the lip, tongue, larynx, soft tissues, or tongue and throat itching. Respiratory signs are cough, bronchospasm, dyspnea, hypoxia, wheeze, stridor, hoarseness, or chest tightness. GI signs and symptoms could include edema, dysphagia, abdominal cramping, pain, diarrhea, nausea, or vomiting. So they're saying those signs and symptoms in 2 or more systems. So they could have anxiety, skin, issues with the mouth and the throat, respiratory symptoms, or GI symptoms. We're going to provide them with epinephrine, 1 milligram per 1 ml, the 0.3 IM. We're going to give that again and try and give that in the leg. Caution to patients with a pulse rate over 100, cardiovascular disease, hypertension, beta blockers, digoxin, MAO inhibitors, or pregnant. But again, it's caution. It's not a complete contraindication. May repeat after 5 minutes, but don't delay transport. If wheezing, provide albuterol 2.5 milligram and ibuprofen 0.5 milligram respectively via a handheld neb or mask. You can do 6 to 8 liters of oxygen based off of your patient's needs. And then lastly, we'll be providing diphenhydramine or Benadryl again, 50 milligram IV push. If no IV, consider IM. Here's a couple of pictures of the signs and symptoms covered in the 2+ rule above. Moving on to the critical severe systemic reaction, anaphylactic shock portion. The above, referring to that 2+ rule list, we can rewind if needed to check that list again, plus alter mental status, decreased or absent lung sounds, severely impaired airway, cardiovascular collapse, hypotension, so systolic blood pressure under 90 or a MAP under 65, dysrhythmias, faintness, syncope, or coma. Initial considerations are going to be epinephrine, again, the 1 milligram per 1 ml, but this time we're going to up the dose to 0.5 milligrams IM while attempting airway and vascular access. Airway access could be OPA, NPA, could be a bag, iGel, or Innovate. It is based off of your patient's needs. If airway and ventilation severely compromised, consider an advanced airway. Do not delay transport waiting for a response. Um, Airways that are going to be found on this type of patient with the allergic reaction due to the swelling of their airway, their mouth, larynx, uh, and all things around there, it's going to be a volatile, difficult airway. So you're going to want to take as much of a chance as you can to try and get an airway completed and sink the tube. If you feel like you want to get aggressive with it, and get aggressive, but understand that if you do miss on the first attempt, introducing the King Vision blade for a second time is only going to add more problems for you. Make sure you got suction on standby as well. As soon as vascular access is successful, start IV normal saline challenges, 200 mL respectively. The goal is a systolic blood pressure at or above 90. Reassess after every 200, naturally. We're going to be providing epinephrine again, 1 milligram per 10 mL, so the 1 to 10. Titrate in 0.1 milligram doses up to a total dose of 2 milligrams. Obviously, if we need to do it through the IO, we can do an IO. If no IV IO, may repeat epi 1 milligram per 1 ml, 0.5 IM again after 5 minutes. If they are on beta blockers or not responding to the epi, feel free to push some glucagon, 1 milligram IV push or IO. The IM-IN injection for the glucagon is a BLS skill. If they are wheezing, albuterol 2.5 milligram and ipratropium 0.5 milligram respectively again. May repeat times 1 while en route. Contact medical control for more doses. Step number 5 is going to be Benadryl, 50 milligrams IV push. Again, give that slow. Definitely don't need somebody you're intubating puking if you're going to be pushing that through an IV. If cardiac arrest occurs, begin quality CPR. Prolonged CPR indicated while signs and symptoms of the anaphylaxis resolve. Start second vascular access line. Give IV fluids as rapidly as possible, maybe up to 20 ml per kilogram. Use a pressure infuser if available. And we'll be providing epinephrine 1 to 10, 0.01 milligram per kilogram up to 1 milligram. So the standard dose for an adult, 1 milligram, epi 1 to 10 every 2 minutes instead of 5. And treat dysrhythmias per SOP. Here's a couple of people that we could consider on that critical list. The lady in the middle, maybe not so much, depending on what her airway involvement is. But the guy on the left has some clear swelling, especially to his airway. And then the guy on the right has a pretty systemic volume of hives. And lastly, the PEDS portion of this allergic reaction protocol is very similar to the adults. The doses definitely line up relatively similar to the doses for an adult, but please, please, please pull out the SOP book if you need to for a pediatric patient. Any other questions, let me know. Feel free to reach out. Thank you.